Hey guys, this is Lab 17 review. We are going over the superior mesenteric artery, inferior mesenteric artery, both coming off of the descending aorta, and then just talking largely about the intestines today with their attachments to the mesentery. So let's get to it. It's decently long. So where would you look to identify jejunum versus ileum in your cadaver? Well, jejunum is in the upper left-hand quadrant. We can see right here. Unfortunately, the transition from jejunum to ileum is gradual, not distinct. However, we can point out two spots where we know 100% we have jejunum, and another spot where we 100% know we have ileum, which is the transition from duodenum to jejunum, and then from ileum to cecum. All right, but ileum is lower right quadrant of the abdominal cavity, and jejunum is upper left quadrant of the abdominal cavity. All right, so starting with the place that we know for sure jejunum is, we have this duodenal junction, and you can see that we have the duodenum coming from retroperitoneal, and then when it goes past this opening, we have this junction, we have the jejunum. So not too bad. The jejunum has a larger diameter and thicker walls than the ileum. It also has these plicae circulares, which increase the surface area available in the jejunum. And you can see these on barium contrast, but they're right here, these wavy lines. And then on our barium contrast, to get our x-rays to show the jejunum really well, you can see all these little fuzzy lines, and these are the plica circulares that have a dense follicular appearance. And then importantly, the mesentery of the jejunum is relatively fat-free, so larger diameter. You should be able to notice a difference in diameter between the jejunum and the ileum. Thicker walls that you can palpate a difference in. And then if you were to dissect it, you should see a whole lot of these circular folds in the jejunum, and we will see less of them in the ileum. And then the mesentery of the jejunum has less fat. All right, beyond that, so when we talk about the ileum, ileum has, it's 3/5 of the small intestine, narrower diameter compared to the jejunum. And then importantly, notice here the circular folds here versus here, right? That's a pretty big difference. Internally, you have the plica circulares have undergone a gradual decline the further away you get, or further towards the cecum you get, and they're absent at the ileocecal junction. The mesentery of the ileum has more fat than the jejunums, and then we haven't talked about this yet, but with the arcades, so we have branches of the superior mesenteric artery gives off these arcades, which you can see here, and for the ileum, they're relatively complex in the sense that simple versus like simple squamous, single layer versus like stratified. So we can say that these are kind of like stratified almost, and then they end in these short straight vein or short straight arteries called the vasa recta that goes directly to the walls of the ileum or jejunum. But specifically for the ileum, you have these complex 2 to 4 layers of these arteries from, again, branches ultimately from this superior mesenteric artery. And then for the jejunum, it's only 1 to 2 layers, so not a whole bunch of layers like we see here. And then the jejunum has long vasa recti, right? These are the vasa recti on the ileum, they're relatively short, and on the jejunum, they're relatively long, these vasa recti right here. Okay, but simple arterial arcades, and then for the ileum, complex arterial arcades. But then notice the barium swallow X-ray with the jejunum highlighted by the barium swallow. You can see that you don't have the fuzzy appearance, and it's well-defined lumen in comparison to the jejunum. Okay, so what about the blood flow to this region? We mentioned the superior mesenteric artery, and what is going on with that? Is that how the jejunum and ileum are getting blood? The answer is yes. So starting off, and we'll take a look at this more in a second, but remember our friend the celiac trunk, and the celiac trunk comes from the descending aorta. So the superior mesenteric artery also comes from the descending aorta. So we branch off the descending aorta. And can you find the superior mesenteric artery? Yes, right here. It's vertebral level. So we can see here this cross-section. Here's our descending aorta. Here's our celiac trunk, which we know is going to give branches for the stomach, liver, spleen. And then down here is our superior mesenteric artery going to the mesentery. And then it's going to give on the left side here. We can see as we go down, you have branches coming off for the jejunum arteries that you can see will form arcades and then lead to long vasa recta. But this is coming off the superior mesenteric artery. And then you can skip this. What's the vertebral level? It's L1 to L2 approximately is where the superior mesenteric artery branches off of the descending aorta. Okay, so specifically we started talking about the jejunums. Blood supply is coming from the superior mesenteric artery. They're the jejunal branches overall. It's on the left side of the superior mesenteric artery and passes through 2 different layers of mesentery to form simple singular arcades, at most 2 levels of arcades, but generally singular arcades, and then gives rise to those long vasa recta, and then anastomose with each other inside of the muscle of the jejunum overall. All right, so branches off the superior mesenteric artery are giving our jejunal arteries. Those become sort of circle around and become jejunal arterial arcades, which you can see here, and those give rise to vasa recta, which are exceptionally long for the jejunum, and then those anastomose with each other inside of the walls of the jejunum itself. Okay, for the ileum, it's pretty much exactly the same. Instead, you have of jejunum branches, you have ileal branches from the superior mesenteric artery. So you can see these branches here are coming off of the superior mesenteric artery, again, on the left-hand side. This is left. And they are forming complex arterial arcades, which you can see here, right? There's many, many layers. It's not just like 1 or 2 over here. And then those lead to relatively short vasa recta overall. Okay, so not too bad. Basically, the left-hand side of the superior mesenteric artery is going to give rise to the jejunum arteries and the ileal artery branches, which in turn will form arterial arcades, and then those arterial arcades will give rise to straight arteries, aka vasa recta. And jejunum has long ones, ileum has short ones. Jejunum has simple arterial arcades, ileum has complex, multi-layered arterial arcades. Okay, but both coming off of the superior mesenteric artery, which comes from our friend the descending aorta. Okay, at the level of L1 to L2, so not too bad. All right, where does the superior mesenteric vein drain? Well, the nice thing is that for the ileum and jejunum, the venous drainage follows the accompanying arterial vasa recta and arcades in the mesentery, and then they drain to the superior mesenteric vein, and then the superior mesenteric vein is going to drain into the, so you can see the superior mesenteric vein here. We can see that the veins are following along with the jejunal branches here, and they're following along with the arcades and the vasa rectas, and then you see the ileal branches here following along with the ileal branches of the superior mesenteric artery. So the superior mesenteric vein is going to drain into the hepatic portal vein, which makes a lot of sense, right? The blood return we're getting from these intestines is going to be nutrient rich. We're going to want it to go to the liver. So superior mesenteric vein is going to drain into the liver, and then of course we know that after that it's going to go out of the liver via the hepatic veins and directly into the inferior vena cava and then back to the heart. Okay, and then we're going to see a little bit later that we talked about the left side of the superior mesenteric artery, and we've now talked about the left side of the superior mesenteric vein, but the right side is going to deal with our colon. Okay, so I added these slides on the lymphatics overall because I think it's important to know. It's really not that complicated. It's just, start with our lumen of the small intestines. Then we know we have the lacteals that exist within our villi. Those lacteals are going to drain into lymphatic vessels, which will drain into lymph nodes within the mesentery. And the naming of this is a little bit weird because, as you can see in this diagram we were given from lecture, you have superior mesenteric lymph nodes and then superior mesenteric lymph nodes up here. Other sources just call these mesenteric lymph nodes because they're in the mesentery. The nomenclature that I saw is that if you are associated with branches from the superior mesenteric artery, you can call them superior mesenteric lymph nodes because these lymph vessels follow along with the branches of the superior mesenteric artery. Okay, so from lumen to lacteal, from lacteal to lymph vessel, from lymph vessel to lymph node, from lymph node to, depending on how you find it, superior mesenteric lymph node. Again, I suppose if you're closer to the superior mesenteric artery, you'd be considered superior mesenteric lymph node versus just regular mesenteric lymph node. But I think it's kind of a distinction that's probably not super important. If you were drained to the inferior mesenteric artery, then you would be called an inferior mesenteric lymph node. So I think that's an important distinction. Probably best to just stick with calling all of these superior mesenteric lymph nodes as they follow along with the branch of the superior mesenteric artery. We haven't talked about the inferior mesenteric artery yet, but that will come into play. Okay, so once you have gotten to the superior mesenteric lymph nodes, then you're going to drain into the cisterna chili, which you can see here is this sac-like structure, which will then drain into our friend, the thoracic duct. And we know the thoracic duct is going to drain into the junction between the internal jugular vein and the subclavian vein right here, which comes off of the brachiocephalic vein, which goes into our superior vena cava. Okay, so not too bad. Then we have our innervation of the small intestines. Well, we're familiar with the enteric nervous system for peristalsis and glandular secretion, aka submucosa, and then the mesenteric plexus. We of course know that the parasympathetic and sympathetic nervous systems will have an influence on this, and so the parasympathetic nervous system is rest and digest, and in particular, the preganglionic neurons are going to come down from as part of the vagus nerve, and then these preganglionic neurons are going to go all the way to the mesenteric plexus, so very long, but they are going to be present in the left and right vagal trunks for the small intestines, and vagal stimulation is going to increase peristalsis and increase glandular secretion, which is consistent with rest and digest, and we can see that here. Our two vagal trunks will continue down, they'll go through our plexi, or in fact make up the plexi, our different plexi, the prevertebral plexus and the superior mesenteric plexus, and then it will get to its postganglion within the wall of the organ itself, and then the postganglionic neuron itself is very short. Okay, so then we have sympathetic nervous system. Importantly, we should mention the vagus nerve does midgut and foregut. Hindgut is done by the pelvic splanchnic nerve for PANS. I'll talk more about that later. The sympathetic nervous system is going to do fight or flight, so reduce blood flow, decreasing glandular secretions. The preganglionic neurons are from our thoracic splanchnic nerves, which we're familiar with, in particular the greater splanchnic, lesser, and least splanchnic nerves. This is preganglionic. They're going to synapse on one of the four major ganglia in the abdominal region. There's the celiac, aortico-renal, and then the superior mesenteric ganglion, and then the inferior mesenteric ganglion. For the small intestines, the superior mesenteric ganglion is what these splanchnic nerves are going to synapse on. After they've synapsed on the superior mesenteric ganglion, which you can see here, they are going to have the postganglionic axons follow the superior mesenteric arteries and the branches to innervate the small intestines and synapse on the enteric plexus. Okay, we also have the lumbar and sacral splanchnic preganglionic neurons for lower down overall for the sympathetic nervous system. But as we're dealing with here with the small intestines, ileum, and the jejunum, we're concerned with greater, lesser, and least, but mostly greater overall. Okay, so postganglionic follows the superior mesenteric artery branches. For sensory innervation, we have distension, so stretch receptors, this is different than our pain, and they're going to send information to the medulla via the vagus nerve. And then pain receptors that are for excessive stretch or ischemia, aka poor oxygen, is going to send via the sympathetic nervous system, splanchnic nerves, pain signals back to the brain with the cell bodies of these pain receptors located in the dorsal root ganglia of T5 through T12. But importantly, the small intestines are insensitive to touch and cutting or burning. Okay, some clinical correlations here. We have Meckel's or ileal diverticulum. Basically, when you're an embryo, you have this vitelline duct that normally goes away. Sometimes it doesn't, and you're left with this little diverticulum overall in the ileum. And this normally won't cause any problems, but if it becomes infected, it can be kind of like what happens with the appendix. So you have high fever, intense abdominal pain, and elevated white blood counts. So it's the Meckel's diverticulum in the ileum. Then you have small bowel ischemia, which we know ischemia is poor O2 content in the blood to a particular region. So that could be due to, say, thrombosis within the superior mesenteric vein or artery, and then you're going to signal our pain receptors, which we know we're traveling along the sympathetic nervous system, splanchnic nerves, and so we know splanchnic is T5 through T9 for greater, T10 through T11 for lesser, and then T12 for least. And so what we're dealing with is if you're feeling pain in the jejunum or ileum, it's going to mostly be the greater splanchnic and then lesser splanchnic. So T6 through T10, T7 through T10, and so T6 through T10 right here. And you can see referred pain to the front of the abdomen around the umbilical region. So intense pain around the umbilical region due to ischemia of the small intestines. Okay, peritoneal coverings of the large intestine. There's not too much to know here. Descending and retroperitoneal are or descending and ascending colon or retroperitoneal. Parts and features of the large intestines, well, we have our friend the cecum, then we have the appendix coming off of it, we have ascending colon, then we have the ascending becomes the transverse colon, and as it does that, you have the right colic flexure, and so flexure you think of as flexing a bend, and right colic, so right side, we're on the right side, colic just meaning related to the colon, this is the colon, aka large intestine, and then you could also say, you call this the hepatic flexure, why? Because you have, the liver over here. Then after going, after the ascending becomes transverse, then you become descending, and then you go same logic, you have another flexure, so this is the left colic flexure, left side of the body, colic because it's associated with the colon, and then flexure is bend, and then splenic, we know that the spleen is located on the left side of the body. Then you have descending colon, sigmoid colon, and then we end in the rectum and anal canal, okay? Features of the large intestine are pretty straightforward. We have, this very large lumen, large diameter, 4 to 6 centimeters, with 1 inch being 2.5 centimeters. It's got thin walls. It has our 3 tennae coli instead of the continuous longitudinal layer that we saw in the small intestines. The tennae coli are not present on the appendix, rectum, or anal canal. The appendix has, a complete circular band, as we actually have all 3 of our tennae coli merge on the appendix to give complete circular band of longitudinal muscle. And then the rectum and the anal canal, you just have the disappearance of the tennae coli overall. But there are 3 different tennae coli defined by what they're associated with. So you have the mesocolic, which is associated with the transverse mesocolon, the Mesentaric, that is holding the transverse colon in. You have omental, which is associated with the greater omentum, and then you have the free tennae coli, which has no mesenteric attachment. It's on the posterior surface of the transverse colon. Okay, other features of the large intestine, we have these haustra. And then you can see that here they're defined by the semilunar folds on the inside, and so you can see that these semilunar folds are not a complete circle, but they look like maybe half moons, which is why they're semilunar. Okay, then you also have these little guys right here, which are eplicolae. I can mispronounce that. They're small fat-filled pouches covered by peritoneum, but these fat-filled pouches are the epiloic K. Mispronounce that for sure. Okay, moving on. Can you describe the cecum? Does your cadaver have an appendix? It does have an appendix. The cecum is this guy right here, and it lies in the iliac fossa, which you can think of as the hip region. And it's in the lower right quadrant of the abdominal cavity. It is 5 to 7 centimeters in width and length, so it's pretty wide. It has the ileocecal valve, which has pore sphincter ability, but generally backflow doesn't occur. And the reason that was given to us in notes is that the lumen of the cecum is just so much larger than the lumen of the small intestines that backflow is just, there's just so much room here that it's unnecessary for anything to flow back into the ileum. Okay, then we have the appendix right here, and it's suspended by the mesentery called the mesoappendix. So not too bad, but we do know that it does not have the tennae coli and is complete longitudinal muscle. And then the blood supply to this area of the intestines is pretty straightforward. I made a little diagram. So we have the descending aorta. That's going to continue on to become the left and right iliac artery. They also give off our inferior mesenteric artery, but we're concerned with a branch of the superior mesenteric artery because we said this superior mesenteric artery is going to be supplying this entire region. We already saw it supply the jejunum and ileum with its branches on the left side, but now we're dealing with the branches on the right side of the superior mesenteric artery. So this guy gives off 3 major branches, middle colic, right colic, and ileocolic, and so it's this ileocolic branch that's going to give off 3 branches we care about, in particular the anterior cecal artery, posterior cecal artery. Together those supply the cecum, and then the appendicular artery, which supplies the appendix. And so you can start to see this. We have the superior mesenteric artery sort of wrapping around, finishing up. It anastomoses with its final branch, which had come off earlier, which is the ileocolic. The ileocolic is going to branch and give us a posterior cecal artery. We have the anterior cecal artery, and then we have the appendicular artery overall, which we can see appendicular comes back around, goes underneath here, and then back around to supply the appendix. Okay, not too bad. Let's look a little bit more at the blood supply for the overall large intestines before we move on. So this diagram I added myself, pretty much looking at, as we said, we've already dealt a little bit with the left side of the superior mesenteric artery, but we haven't talked about, what's going on with the inferior mesenteric artery. So let's start with the superior mesenteric artery. We have the right side of the superior mesenteric artery. The left side would just be branches to our ileum and jejunum, but the right side, we have these 3 major branches coming off, the middle colic, right colic, and ileocolic. The middle colic is going to give off a branch, and in doing so supply the transverse colon, the left middle colic, and then right middle colic descending, and then the right colic artery is supplying the ascending colon. It will give a branch to 2 branches, the ascending right and then descending right, and then you can see the anastomoses with each other. With just follow this diagram. Then we had the ileocolic, which we already said was for the distal ileum, cecum, appendix, and the proximal ascending colon. That's giving off 5 branches, ileal branches, posterior cecal, anterior cecal, appendicular, and then the ascending colic artery, which is anastomosing with the descending right colic artery. All right, so not too bad. Let's look at the inferior mesenteric artery, which is another branch off the descending aorta. This guy is going to give off 3 main branches in the sense that there's 3 categories. The first is the left colic artery, which we see here, and that's going to split and give us the ascending left colic artery, which is supplying the descending colon, and then as it goes further up to anastomose with the left middle colic, is going to supply the transverse colon as well. Then you have the descending left colic, which is going to anastomose with our next part, but it's supplying descending colon. The next category of branches, there are 3 to 4 of these. They're all called sigmoid arteries, so basically branches from the inferior mesenteric artery that are supplying the sigmoid colon. All right, so descending colon, and then sigmoid arteries are doing sigmoid colon, and then those are going to anastomose and anastomose with the descending left colic artery overall. The final branch of the inferior mesenteric artery is the superior rectal artery, and that supplies the superior rectum. Okay, so this diagram is showing the exact same thing, but importantly we have our descending aorta here. We can see that it gives rise to the superior mesenteric artery. We have all the mesentery removed here, so we can just see the veins. You can see that the left-handed side of the superior mesenteric artery has been removed. These are all of our branches to our jejunum and ileum. And so then we have our first major branch, which is our middle colic. Then we have our second right colic, and then our third ileocolic. And then you can see ileocolic is anastomosing with the superior mesenteric, which is branched off of. And then we know that all of these guys are ultimately, anastomosing with each other. And so we have this sort of, we'll get to in just a second, this marginal artery that comes as a result of that. But moving on to the inferior artery, inferior mesenteric artery we see is coming off of the descending aorta, and you see the left colic, which is splitting already. And then you have your sigmoids right here, continuing inferior mesenteric artery, and then we have our superior rectal artery overall. And you can see that the sigmoids are actually making arcades, arterial arcades, and ending in some vasa rectas, overall, okay, just another word for straight arteries. Okay, not too bad, but importantly, we've touched on this, you can see that all of these branches of the superior mesenteric artery, middle colic, right colic, iliocolic, are anastomosing with each other, and they're forming this marginal artery, right? And same thing on this side with the inferior mesenteric artery, you have all these basically anastomoses of the sigmoid artery with the left colic, and they are forming overall this marginal artery. And so the marginal artery is significant because it's made from anastomosis only, therefore it's called like a physiological artery. It's basically a bunch of other arteries put together. And then it provides redundant blood supply in the event of thrombosis, aka blockage, to either of the superior mesenteric or inferior mesenteric artery. And so if you have a blockage here, then this region over here is still going to get blood supply, right? You still have anastomoses within the walls. And importantly, for surgery, because you have so much anastomoses, you need to clamp the marginal artery to, if you're operating on, say, like this region here, and you're like, okay, well, this region, is ascending colon, so I'm thinking that's going to be right colic artery, so okay, I'm going to go ahead and clamp this guy. Well, you're going to need to clamp the marginal, or the marginal artery to basically keep blood from flowing to this region while you're doing surgery, so you're going to need to clamp here and here instead of just like here, right, because you have all of this anastomosing overall. Okay, can you discuss the venous drainage of the large intestines? So it's not too bad. Really, you have, just like with arteries, you have a superior mesenteric vein and an inferior mesenteric vein. Superior mesenteric is drained for the cecum, ascending colon, transverse colon, and appendix. And you have, going into the superior mesenteric vein, the right colic, and you have the iliocolic veins. And then on the going into the superior mesenteric vein, which is itself going into the hepatic portal vein, which we know is going through the liver to hepatic veins, inferior vena cava, and then right atrium. On the other side, with the inferior mesenteric vein, which is applying drainage for the descending colon, sigmoid colon, and proximal one half of the rectum, so top of the rectum, you have the superior rectal vein, sigmoid, and then left colic, and that's draining into the inferior mesenteric vein, which we see is draining into the splenic vein, which is then draining into the hepatic portal vein. And then notice how you don't have a middle colic vein, whereas we had middle colic artery right here. Okay, so moving on. For innervation, this is a huge mess, but we know we have the enteric nervous system as well. The sympathetic innervation of the large intestines is really broken in two parts. You have a proximal part, which is defined as really this entire region, and then you have a distal part, which is descending colon and then rectum and anal canal. And so for the proximal part, you have the preganglionic sympathetic nervous system is from our thoracic splanchnic nerves, our greater lesser least, and then it's going to synapse in the celiac ganglia or superior mesenteric ganglia. And if you can recall, we said that there's actually 4 ganglia within the abdominal region that are significant. We have the celiac, aortocorenal, superior mesenteric, and mesenteric. And so we're going to be dealing with this guy and this guy for the proximal part of the innervation for the sympathetic nervous system, for the proximal part of the large intestines. All right, so thoracic splanchnics to celiac ganglia and superior mesenteric ganglia, and then postganglionic, it's going to travel with the basically arterial branches that are supplying the region of the large intestine in question. And then for the distal part, descending colon and rectum, it's the lumbar splanchnic, which is L2 to L1 to L2 for preganglionic. Then for ganglion, it's going to synapse. These guys are going to synapse at the inferior mesenteric ganglia. And then you have postganglionic, it's just traveling the branches of the inferior mesenteric artery. And then for the parasympathetic nervous system, and so let's just say we can point this out really quickly. So for the proximal part, you have the least splanchnic, greater, lesser. They're going to synapse on the superior mesenteric ganglion or the celiac ganglion, which you can see here. And then postganglionic, they're going to travel along with the blood vessels. For the distal part of the colon, you are going to be dealing with the lumbar splanchnic nerves. They're going to synapse on the inferior mesenteric ganglion, and then it's going to trace along with the inferior mesenteric arteries. And then for parasympathetic, you have the anterior and posterior vagal trunks for the proximal part of the large intestines, and then it's going, those neuron axons are going to pass through the prevertebral plexus and then travel with the superior mesenteric artery branches to this proximal part of the colon. Okay, so travel from the vagal trunks, posterior and anterior vagal trunks, through the prevertebral plexus, and then along the superior mesenteric arteries to the proximal part of the large colon, and then proximal part of the large intestines. And then distally, you have the pelvic splanchnic nerves, which are located in the ventral rami. The bodies are from the ventral rami S2 to S4, and then their axons are going to pass through the left and right inferior hypogastric plexus, which we can see here and here. And you see that we have these splanchnics are here, so they're passing through this region, and then passing through the superior hypogastric plexus, and then going to our distal part of our large intestines overall. All right, and then sensory innervation, it's traveling with the splanchnic nerves from the sympathetic nervous system to dorsal root ganglia. Okay, we're just about done. Large intestine clinical correlations. So bowel obstruction, basically if you have a whole lot of feces that are impacted in your colon, you can get backed up. Typical causes are from, say, Crohn's disease or volvulus, twisting of the large intestine, mainly the sigmoid colon, or from extra feces, you just haven't pooped in a while. Peritonitis is an intestinal ischemia, lack of oxygen, infection, possible rupture of the blocked intestine, and then that's leading to infection gaining access to the peritoneal cavity. So peritonitis is basically an infected peritoneal cavity. This can lead to death. You can see it here, inflamed digestive system. This is normal. This is inflammation of the peritoneum. Diverticular disease, aka diverticulitis, is you have these outpouchings in your small intestine and large intestine and causes inflammation, localized infection. I've actually known some people with this, and it is very painful. Then you have intussusception, which I've heard of happening to kids. One part of the small large intestine slides into an adjacent part, and then typically they'll blow air into the region to inflate the small intestine, and they'll just pop out of each other. All right, and then if you were to want to block chronic visceral pain, we said that there are 4 main ganglia in this region: celiac, inferior, and inferior mesenteric, and then we have the aortico-renal. And so you can target those ganglia to basically block pain signals from traveling through them to the brain. Okay, just a quick word on the hepatic portal system. So we have the blood drainage into the liver through the hepatic portal vein, but importantly, we have 3 portal vein and systemic vein anastomoses, and these are sites of potential issue if you have portal hypertension. So specifically, you have, we've already talked about this one, but with the umbilicus region, you have the para-umbilical portal veins, and those are going to anastomose with veins on the anterior abdominal wall. And so if you have hypertension here in this portal vein, then you're not going to be able to get good drainage into the liver. And so you'll have huge distension of these vessels on these veins on your anterior abdominal wall. And that was the caput medusae veins that we saw at the head of Medusa, really distended looking abdomen veins. Then you also have a anastomose with the systematic venous system at the anal rectal region, where you have the superior rectal vein from the inferior mesenteric artery. We talked about that, and it's going to anastomose with rectal veins from the inferior vena cava, specifically the middle and inferior rectal veins. And if you have extra blood in this region, you'll have, or high pressure in the portal system, you'll get hemorrhoids. Basically, distended blood in the systematic veins is going to be called varicose veins, and then if it occurs here, if either of these guys get swollen, they're called hemorrhoids. And then your final anastomoses between portal and then you can also have blood in your stool if you have hemorrhoids from this region, or from this. And then the final one is the gastroesophageal region, which is up here, and you could cough up blood as you have anastomoses with a branch of the portal vein as well. Okay, so that's it. It was pretty long, and unfortunately our software doesn't show this region very well, but good job, guys, and we'll see you next time.